and it seems like of folks who are on, y'all all know John Fortney, and that may be why that you're here. I met John when I moved to Little Rock in 2009 to work at the VA, and they said, go to primary care. And I was like, what do I do there? And so didn't even realize the wealth of knowledge and information that we had over there with John and his colleagues who had published a lot. So really been happy to get to talk to John. And over the years since he left Little Rock and went to University of Washington, I've been able to call him and say, what, help me with this, help me with that. So it's been great. But so I think most of y'all know John as a director of the Division of Population Health and professor of psychiatry and behavioral health at University of Washington, and has published a lot in collaborative care management, and specifically about using telepsychiatry collaborative care. And so very glad for you to be here, John. And if you'd like to say some more about what you're doing, as well as this project that you're going to tell us about.
Yeah, I mean, we're doing trials of integrated care for more complex psychiatric disorders than we've done in the past. So not just depression, anxiety. And so, yeah, this trial focuses on PTSD and bipolar disorder. Just to acknowledge some of my colleagues, there's actually too many to put on a slide. Jürgen Unitzer is the co-PI of this. Deb Bowen really helped us with the stakeholder engagement part of this PCORI trial, which PCORI requires. So Sarah Melli led one of the arms, the telepsychiatry referral arm, and Amy Bauer led the telepsychiatry collaborative care arm. Feel free to kind of jump in and ask questions anytime. I think the group's small enough we can do that. I want to just start out with a little epidemiology, which might surprise some of you, maybe not. In primary care, about 20% of patients screen positive for PTSD. Clinics don't typically screen for PTSD, but if they did, they would find lots of patients. It's even higher in the VA. According to the National Comorbidity Study, most of patients with people with PTSD, only about a third get any specialty mental health care in the year, and only 22% see a psychiatrist. So they're being treated in or not treated in primary care, where the quality of detection treatment is poor. Only 15% of patients screening positive for PTSD end up with a documented diagnosis in the medical record. 12 years elapses between the onset and diagnosis of PTSD on average. That's a long time to suffer. And only 20% of primary care patients with PTSD receive adequate care. So that's part of the problem.
And John,
yeah.
John, that's assuming the adequate care took place somewhere else, right? Not in primary care?
Yeah, that 20% is adequate care in primary care.
In primary care.
Yeah.
That's actually surprisingly high number.
Well, you can get adequate care, quote unquote, if you have an adequate trial of an antidepressant.
Okay.
So 2 months on antidepressant, you're called adequate care. Low bar.
Maybe it's minimally adequate care.
It should be minimally adequate care. Bipolar disorder is actually very similar. The prevalence is obviously lower, but of those on an antidepressant, a quarter of them will screen positive for bipolar disorder. So that's a worrisome statistic. And again, according to the National Comorbidity Study, only a third of people with bipolar disorder get any specialty mental health during the course of a year, and only 23% see a psychiatrist. So they're also kind of in there in primary care, where the quality of detection and treatment is even worse. One study found that 0% of patients screening positive for bipolar disorder had a documented diagnosis. 6 to 8 years elapses between onset and diagnosis. 72% receive an inappropriate medication. So that means an antidepressant with no mood stabilizer. That's a real concern. And 18% are receiving no medication.
Hey, John, was there any look at inappropriate diagnosis of bipolar disorder? Because that's actually what we see a whole lot. Or is this too old to, predating everyone now has bipolar if they're angry?
You know what? We have some good data on that. I'll share with you.
Okay.
Yeah. So The problem is that there's highly effective treatments for both these disorders, but primary care patients don't have access to it. Typically what happens is, even if it gets detected, primary care providers pretty much don't want to deal with it. So they refer the patient to a community mental health center or other specialty care setting. They get in the car, and they got to navigate to a different healthcare system. There's usually long wait time, it's expensive, so they don't go. And a large portion of patients with these two disorders are unable to engage in specialty mental health. They're exclusively treated in primary care. And typically what they get is medications prescribed for depression, which is what is detected by the primary care provider or diagnosed by the primary care provider. And primary care providers, our qualitative work shows that they're increasingly challenged to care for these patients with psychiatric disorders. They feel obligated, but unprepared and under-resourced. So that's a problem that the SPIRIT trial is trying to tackle. We came up with basically two solutions. One we called telepsychiatry, telepsychology enhanced referral. And that's where we bring the telepsychiatrist and telepsychologist into the primary care clinic via interactive video. In this trial, the telepsychiatrist would prescribe medications. Actually, they met with the psychiatrist first to establish diagnosis and come up with a treatment plan. If that treatment plan involved medications, they would prescribe the medication. If it involved psychotherapy as well, a telepsychologist would deliver cognitive processing therapy for PTSD or cognitive behavioral therapy for bipolar depression. The telepsychiatry collaborative care model, on the other hand, most of you are probably familiar with this. That's where we have a on-site care manager and an off-site telepsychiatrist consultant who's supporting the primary care provider, so they feel more comfortable treating these complex disorders. The care manager keeps the patient engaged in care, promote adherence to medications. In our case, we trained them to deliver behavioral activation to patients. They use measurement-based care to track symptoms, and they consulted with the telepsychiatrist when patients were having problems not responding to treatment. Something we did differently for these two disorders, which most collaborative care programs don't do, is we had every patient see the telepsychiatrist for a consultation to establish the diagnosis right up front. So they met with the care manager told them they were going to meet with a telepsychiatrist. They met with that telepsychiatrist for one visit, just to make sure that diagnosis was correct, which was particularly important for bipolar disorder.
So no prescribing or anything at that appointment. It was just confirming the diagnosis, John?
That's right. The PCP did all the prescribing for this model for bipolar disorder and PTSD, which typically, they're not comfortable with, but we'll see what they said about that.
It's my litmus test of trust. If I can get them to prescribe lithium, I know they trust me. That takes about 6 months to get them to do it. So I'm real curious what you did.
In terms of integrated care models, this pyramid kind of shows the different types of integrated care, starting at the bottom, which is a really low touch curbside consultation where a provider asks a specialist for advice. That can apply to a large portion of patients potentially. Then you move up to a consultation liaison where there's a one-time consult encounter. That can also, there's resources to do a lot of that, just because one visit. Then moving up, there's the behavioral health consultant model, probably the most popular type of integrated care, where you have warm handoffs and the behavioral health consultant on site will see the patient every time they're in the clinic for physical health disorders. And then we have collaborative care, which I just described, and then telehealth referral care, where it's co-located, non-integrated. So the top of the pyramid, since the mental health specialists are taking over treatment, they can really only manage a small number of patients compared to collaborative care, which can manage, as we'll see, up to 6 times as many patients with a specialist. And so that's what the SPIRIT trial was comparing, those two top of the pyramid models, to see which has better outcomes, knowing that collaborative care has the capacity to treat a lot more patients than does referral, because the psychiatrists are just providing consultation. We did this in the biggest healthcare system in the country, one of the best kept secrets. If you haven't heard of federally qualified health centers, this map shows where they are. There are 1,400 grantees of FQHCs, I'll call them. They have 13,000 clinic locations, and they treat 30 million Americans. So by far the biggest primary care system in the country, but basically a safety net primary care system. Almost half the patients live in rural areas, 91% live in poverty, 62% are racial ethnic minorities. They almost all offer on-site mental health services, but only 12% of their staff are psychiatrists and psychologists. So there's like one psychiatrist and one psychologist for every 50,000 patients. So they don't have the capacity to do it themselves on site. We did this project with 24 clinics and 12 FQHC systems in 3 states. We did it with in Washington State, where the University of Washington psychiatrists and psychologists has provided care in both arms to 4 health centers throughout the state. We did it with the University of Arkansas for Medical Sciences. Jeff Pine was the PI, with 3 FQHCs in that state, in the Mississippi Delta and the Ozark Highlands. And Paul Pfeiffer and his staff at the University of Michigan, we did it there with 5 FQHCs throughout Michigan, including the Upper Peninsula. So one of the things we ran into early was this issue that we had run into before in the health centers. The FQHCs were worried about right in the beginning, which is they didn't really want their patients navigating to a different healthcare system, meaning the university healthcare system. There are logistic barriers to becoming a patient at the medical center. The paperwork burden of intake is actually quite high. There's the unfamiliar system for scheduling appointments. This is even if it's televideo. There's attitudinal barriers. There's lack of trust of the medical center research institute. There's stigma associated with having to be being so sick that you're treated at the university medical center. And we've actually seen a real difference in engagement in telepsychology in 2 RCTs we did, one in the VA, which is an integrated system of care. You can get referred to a telepsychologist, and it's the same as your primary care clinic in terms of making appointments, et cetera. And 55% engaged in telepsychology. We did a similar trial in FQHCs where they had to become a patient at the University Medical Center, and basically the same intervention was offered, free telepsychology, and only 17% engaged. So we did not want for patients in either of our arms to have to become University Medical Center patients. So what we did was we had the telehealth providers credentialed and privileged to practice at the FQHC. So essentially became FQHC patients. And we believe that this increased patient access and engagement. It also increases quality and safety because the providers had access to the electronic health records. They could see what their current diagnoses were. They could see their medications. They could do e-prescribing if they were in the referral arm. They could order lab tests and view the results. And they could communicate with the primary care provider using the EHR. And for FQHCs, this actually increases the potential revenue because they get higher payments in most cases than the university would if they saw the patient. So it actually increases financial sustainability. However, to practice at the FQHC instead of the university, there actually was difficulties involved in that. They had to become credentialed and privileged, and that is a pain, as you all know, and can take a long time. We had to get them EHR remote access, which is more expensive than I ever knew it was. And they had to learn multiple EHRs, which was a burden for the Tele-Providers. To get reimbursed, they had to then become credentialed and paneled with all the insurance companies at the FQHC. And they had to figure out how to bill with telehealth, which was not easy in any of our states. And then they had to set up a contract. The FQHC had to set up a contract back to the university to buy their time since the FQHC was billing. And then there were special indemnity concerns as well. They had to buy, FQHCs had to buy special insurance. So something that's really cool is that we got the Tele-Providers to practice as FQHC providers, but did want to let you know that that was, we had to overcome a lot of barriers to do that. So here's the overall trial design. We started off by screening, doing universal screening for bipolar disorder and PTSD. We didn't want to have a lot of false positives, so we only screened patients that screened positive for depression on the PHQ-9. All the FQHCs do universal screening for depression with the PHQ-9, and the 20% or so of patients who screen positive would then get the CIDI for bipolar disorder and the old PCL6, which was the best thing at the time for PTSD. And I'll tell you how that screening went in a minute. So they would then did a baseline survey. When they completed that, they would get randomized to telepsychiatry collaborative care or telepsychiatry enhanced referral. The referral arm was actually an adaptive intervention. So this is a SMART trial design, if you're familiar with that term. And at 6 months, if the patient hadn't had 2 encounters with their referral providers, they would get re-randomized, 1 to more telepsychiatry enhanced referral, and another to what we call phone psychiatry enhanced referral, or phone enhanced referral. And the difference between these is that in the telepsychiatry enhanced referral, the providers just treated patients who showed up to their appointments. You know, collaborative care is population-based. If patients miss appointments, the care manager makes sure they don't fall through the cracks. Very much working with the registry, population-based. The referral model is not like that. You show up, you get treated. You don't show up, you get forgotten, which is the way most referral care is like. For the phone referral, you didn't get forgotten. So at 6 months, the psychologist would call the patient back and try to use motivational interviewing or other approaches to try to get the patient to re-engage or to initiate for the first time care with the referral arm. We had great expectations for this. As you'll see, they didn't really pan out, but that's what that's about. So over 3,000, this is the top part of our consort diagram, over 3,000 patients screened positive. About a third of those screened positive for bipolar disorder. And almost, I'll show you in a second, but almost everybody screening positive for bipolar disorder also screened positive for PTSD. So that 1,000 screens there for bipolar disorder is bipolar disorder plus PTSD. And then another 2,000 screens for just PTSD. Only 22% were not eligible for one of our exclusion criteria. And by far the most common reason, like 88%, was that they were already being prescribed psychotropic medications by psychiatrist or psychiatric nurse practitioner. If patients were already engaged in off-site specialty mental health with a prescriber, we did not want to mess with them. So they were excluded from the trial. We didn't want to interrupt that care, maybe end that care, and then at the end of the trial have to have them go find another specialty provider. So that was basically our only exclusion criteria. About 2/3 consented to participate. So we had 1,200 consents and 1,000 patients completed the baseline survey and got randomized. So this is a pretty big trial. Took us 2.5 years to enroll that number. So here are the quantitative findings. Starting off with the socioeconomic characteristics. About 12% were African American, about 8% were Hispanic. Even though we were recruiting, we had everything in Spanish and consent forms, surveys, translators in the clinic. We weren't able to enroll a lot of Spanish-speaking only patients. Last 4 years was kind of tough. And then, but we did get 8% Hispanic, and about 15% were other racial, ethnic, or other racial minorities. So about 2/3 white. About 62% were living in poverty, which reflects the FQHC population. I don't have a pie chart here, but about half lived in designated rural areas. Almost all were publicly insured or uninsured. So 68% were insured by Medicaid, 24% by Medicare, 4% by military, 7% uninsured. So publicly insured or uninsured population. Employment was surprisingly low. We had almost 19% were employed full-time, another 12% part-time, and 50% said that they were looking for work but unemployed.
John, do you know how many were on disability, maybe because of their bipolar or their trauma?
That is a part of that 18% other. People said they were were disabled and weren't looking for employment. I can't remember that number on top of my head. Sorry. They were. This shows some of the preliminary clinical characteristics. So I said, so this is for the consented group. So TCC's Telepsychiatry Collaborative Care, TER is Telepsychiatry / psychology referral care. Like I said, about a third screened positive for bipolar disorder, and almost everybody, 97% screened positive for PTSD. So Joe Cermelli's got a really nice paper talking about the etiology of comorbid bipolar disorder and PTSD that is worth reading. Obviously, as shown in our data and his review of the literature, it's very common for people with bipolar disorder to also have PTSD. It's not obvious why, but it could be that there are early risk factors in life that cause both disorders. Childhood sexual abuse is very common in patients with bipolar disorder. It could be that patients with bipolar disorder have a higher risk of exposure that leads to the PTSD. But for whatever reason, almost everybody in our sample with bipolar disorder also had PTSD. There wasn't a lot of alcohol misuse, so about 20% were considered to be risky, harmful, or severe alcohol use. Drug use wasn't a huge problem, but it was there. So about 35% had either low, moderate, substantial, or severe levels of drug use. A lot of physical health comorbidities, on average 4. Almost everybody reported that they perceived that they needed a treatment for their mental health problems, nearly about 90% in both groups. And 70% in both groups were being prescribed psychotropic medications by their primary care provider, and were still screening positive for both depression and these 2 disorders. So pretty high level of clinical severity, which I'll comment on even more in a minute. So let's talk about the screening. We had this kind of unusual screening approach. Like I said, we only screened positive people who screened positive for depression got the bipolar and PTSD screen. And I got to say, I think it worked really well. So starting on the left-hand side, these are patients that ended up seeing a psychiatrist, which was about 80%. Either saw the telepsychiatrist consultant in the TCC arm or the referral psychiatrist in the TER arm. So they got a gold standard diagnosis. And of those who screened positive for PTSD, 76% were diagnosed by that psychiatrist with PTSD. So that's a pretty low false positive rate. Bipolar disorder, as you guys know, is really hard to screen for, and false positives is a huge problem. One study reported that the majority of patients with a positive bipolar disorder screen actually had a personality disorder. But our approach used just screening those with depression, I think paid off. So we had 44% of patients screening positive for bipolar disorder ended up getting diagnosed with bipolar disorder. So I was actually pretty happy with that, with basically 1 out of every other patient screening positive for bipolar disorder actually having bipolar disorder. I felt like that wasn't creating a huge burden for the primary care clinics chasing down all these positive bipolar screens. They got a pretty good return on that screening, I think. And they diagnosed lots of other comorbid things. So 60% got diagnosed with depression, 37% with generalized anxiety, 13% with alcohol use, 14% with drug use disorder. Any comments on the screening or questions about that? All right. In terms of engagement, both arms did really, really well with engagements. Remember, none of these patients were being seen in specialty mental health, seeing a prescriber in specialty mental health at baseline. This graph shows the proportion of patients with an encounter of each type. So the left-hand side shows the telepsychiatry collaborative care, and over 90% of patients had at least one encounter with their care manager. 80% of patients had an encounter that included behavioral activation, so they were getting a lot of psychotherapy as well. And 78% saw the telepsychiatrist consultant. So that's a huge success, I think, for getting patients who'd never seen a psychiatrist or weren't engaged with a psychiatrist at baseline to actually see a psychiatrist. And the referral arm was equally as well, which was kind of shocking to me. So this is kind of more stigmatizing because the care is being taken over by the psychiatrist and psychologist. But it's actually slightly higher, 79% of patients referred to the telepsychiatrist actually had one visit. And if the treatment plan at that one visit included a telepsychologist, they would get referred over to them. And almost half of the patients had at least one telepsychology visit. I attribute this to the fact that I think, in routine care, you refer a patient from an FQHC to a community mental health center, and you're lucky if you're getting 20% of those patients to show up for an appointment. I think the difference here is they don't have to travel. They stay in their primary care setting. They don't have to navigate to a different system. It's the providers are part of the FQHC. And I think that was surprising to me how many people ended up having at least an initial visit. And here's the kind of the volume of care they were getting. So on the left-hand side is the telepsychiatry collaborative care. As designed, they had on average one telepsychiatry consultation. That was at the beginning of their 12 months of care. And they had 10 care manager encounters over the course of the year. So the collaborative care arm, the care managers are the ones doing the vast majority of the encounters in that arm. So one psychiatrist encounter per patient, per randomized patient. On the right-hand side, I got a mislabel. That's telepsychiatry referral, enhanced referral care. On the right-hand side, the purple there is the psychiatrist who saw the patients about 3 times, and the psychologist who also saw on average patients about 3 times. So in terms of randomized patient, the telepsychiatry enhanced referral has 6 specialty mental health encounters per randomized patient compared to the 1 specialty mental health encounter by the in collaborative care per randomized patient. So collaborative care is using up 1/6 of the specialty mental health resources as the enhanced referral. So that's an important point. Okay, let's look at outcomes. Our primary care outcome was the mental health functioning, the mental health component summary score from the SF-12. And so we had a non-disease specific outcome measure as our primary outcome since we had these 2 disorders. If you're not familiar with this scale, the SF-12 is essentially a health functioning quality of life type of scale. It ranges from 0 to 100, where 100 is perfect health, 0 is dead. It's scored so that the national average is 50, and the standard deviation is 10 points. So at 0 months, it's 0 baseline, patients started off the trial with an average score of about 30 in both groups. So that's 2 standard deviations below the national mean. And frankly, it's lower mental health functioning than you'll see in many specialty mental health care clinics. We were shocked when these numbers started to come in about how poorly these patients were doing at baseline. The good news is that they increased about 10 points. So an entire standard deviation, but as reported on the 6 and 12 month follow-up surveys, which is a Cohen's d effect size of 0.8 for collaborative care and 0.9 for enhanced referral, which is a huge increase. I looked at a lot of trials that used the mental health component summary score from the SF-12, and of all the trials I looked at, only 2 had anything close to this level of improvement. When you look at trials of bipolar disorder and PTSD in the usual care arm, you usually see no change in the mental health component summary score over time. So I don't believe this reflects kind of a regression to the mean, because it's such a big impact compared to other trials, the intervention effect, and other trials have no regression to the mean in PTSD and bipolar disorder on this score. What you'll notice importantly is no difference between the 2 groups. So both groups had basically the same effect, but a 10-point increase in the mental health component summary score. And as I go through the slides here, these different outcomes, you'll see the same thing. So here, this is the PCL5 to measure depression severity. Here, lower is better. People start out moderately severe at a 50, and they drop down about 12 to 15 points over time. Sorry, more than that, 15, 16 points over time, which is a clinically meaningful increase or decrease in symptoms. And again, when you use the PCL5 in clinical trials and you look at the usual care groups, they're usually flatline. There's no regression to the mean. And our increase over time here is very similar to what you see in PTSD specific studies. You will notice there is actually a small statistically significant separation between the 2 groups here, with the enhanced referral doing just a little bit better than collaborative care. It's statistically significant, but it's not clinically meaningful. So the difference here is about 3 points on the PCL, and 10 points is a clinical minimal difference on the PCL. So even though you see something statistically significant here, it's not a clinically meaningful difference. This shows the depression scores on the SCL20. People start out about 2.5 at baseline. Again, that's moderately severe at baseline. And the effect size here is really large. It's about 1, -1 for both groups. And again, no statistically significant difference between the groups. So patients in both groups are showing really large improvements or decreases in depression severity. I won't show the anxiety scores in the GAD-7. It's virtually identical. This graph shows it's just for the patients that's screened positive for bipolar disorders. This is just 1/3 of the sample. We measured improvement in bipolar disorder outcomes with the internal state scale created by Mark Bauer at the University of Boston and the Boston VA. This scale divides patients up into 4 groups: manic or hypomanic, depressed, mixed state, or euthymic, meaning they're neither in a depressed or manic state. At baseline, about 10% of patients were in a euthymic state, which is what you would expect. And this graph shows the increase in the percentage of patients who were euthymic at 6 and 12 months. You basically see it doubling from 10 to about 17% in TCE and 19% in enhanced referral. So a big doubling of number of patients with bipolar disorder who end up in the euthymic mood state. But this kind of breaks it down a little more. I think this is really interesting. So here on the left-hand side, you have the collaborative care arm. Orange is a manic or hypomanic state, purple is a mixed state, yellow is a depressed state, and green's a euthymic state. So baseline, you're seeing in the collaborative care arm, 7% in the euthymic state, 24% in a depressed state, 42% in a mixed state, which is what Joe Ceramelli predicted, and 27% in a hypomanic or manic state. And what you see over 6 and 12 months, if you look at the 12-month outcomes, the number in euthymic goes from 7% to 24%. The number in the depressed mood state stays about the same, 24 to 29, but the group in the mixed state, it shrinks dramatically from 42% to 21%. And the number in the manic state stays about the same. So it looks, and if the referral arm numbers are virtually identical. So it looks like what's happening is we're seeing the improvement coming from the patients who started out in that mixed state and then going to euthymic state rather than those in the manic state. Any comments on that? That's, I think, kind of super interesting. Okay, and we did it while reducing side effects. So at baseline, patients reported about 4 moderate to severe side effects, and by 12 months, they're reporting about 3 moderate to severe side effects. You know, the psychiatrists are probably pushing up the dosages, maybe augmenting with different medications to improve the symptoms. At the same time, they're able to do it by reducing the number of side effects, which probably is also reflected in our primary outcome, that quality of life scale. So the quantitative results, the conclusions that I have is that there's no difference in outcomes between collaborative care and referral care for PTSD or bipolar disorder. So clinics can implement whichever model fits their system the best. And then, but both arms substantially improved outcomes. It improved in a big way mental health functioning. It decreased PTSD symptoms and bipolar symptoms, depression symptoms, anxiety symptoms, and decreased the number of side effects. Importantly, the collaborative care arm generated similarly good outcomes with 1/6 the amount of telepsychiatry, telepsychology time. So if psychiatrists are scarce in the system you're working in, the collaborative care model can generate outcomes that are equally as good as referral care. And even though I didn't show the numbers, there ended up the group of people who didn't engage in care in the first 6 months, when they got randomized to continued telepsychiatry enhanced referral versus phone enhanced referral, there were no differences in clinical outcomes there. There was a slight increase in the number of patients engaging in psychotherapy, but it didn't have an impact on outcomes. So reaching out to patients via phone didn't really have much of an impact. Before I move on to the qualitative findings, I wanted to see if anybody had any comments or questions about our quantitative findings.
So John, just to clarify, once they were referred, or when they were in the collaborative care arm, the treatment depended on what the providers wanted to do.
And the patient.
So it may have been different meds, may have been, some of them got more or less therapy interventions, but both had really good responses.
Right. Yeah. So the patient and the provider decided whether they wanted to do medication or therapy or both.
But you definitely had engagement.
Yeah, we definitely engage people in care. And I didn't report these outcomes, but we have a measure of perceived access that we asked at baseline or pre-baseline and 6 and 12 months follow-up. And patients, you know, had a big improvement in what their perceptions of access to the mental health care they needed was.
And you may be going to talk more about this, but in terms of, were there any issues with just the practical access to internet and rural providers? Were the patients at their own homes, or were some of them in the clinic?
Oh, you know, I meant to say that and I didn't. So the patients had to present to the clinic for their telepsychiatry, telepsychology. So this was post-COVID. Pre-COVID, everybody thought you couldn't treat patients in their homes. It would be a disaster. And so these patients were coming into the clinics, and we basically used Zoom just like we're doing now, and it worked great. There was occasional problems with audio, and you'd have to make a phone call to the clinic. but for the most part, it worked great. The hardest thing logistically was getting people credentialed at the FQHCs, getting them access to the EHR, and having them learn the EHR system. So, Joe Ceramelli worked in 4 different FQHC systems, and they had 4 different electronic health records. So that was a logistical issue that I heard about.
What particular registry did you use?
We used the care manager tracking system.
Okay.
We actually used it for both arms. So both arms use measurement-based care. And I'll point out, since nobody asked, we used the PCL5 for measurement-based care for PTSD, and we made up a new measure for bipolar disorder, which we called the Patient Mania Questionnaire 9. So we used that in conjunction with the PHQ-9 to assess depression and mania symptoms simultaneously. And Joe Ceramelli is about to publish a paper on the psychometrics of that, which were outstanding.
And why not the Altman, John?
Great question. You probably reviewed Joe's paper. The Altman we actually used the Altman, and I didn't report the results because I don't think it was very good measure at all. One is, as you know, the Altman doesn't have a question with responses, with systematic responses like the PHQ-9 does. It basically says, today, did you, and then gives a sentence, a long sentence, 5 of those, which makes it really hard to administer verbally, which is the way a lot of the measurement-based care was done in this trial. And so we decided not to use it for measurement-based care. We did use it for outcomes, and it did improve, not as much as the internal state scale. The other thing is the Altman was really designed for patients with mania, full-blown mania. It was originally designed for the inpatient setting to use on the inpatient unit. And I think it probably does a good job of tracking symptoms over time for patients who start out in a manic state. And as you saw, that most of our patients were in a mixed or depressed state. And we made up the PMQ-9 because all the primary care providers were familiar with the PHQ-9, so they can interpret what it meant much more easily than they could the Altman, which they had no anchors for, no experience using, et cetera. So, we designed it so that, when somebody drops 5 points on the PMQ, it's a clinically meaningful difference, and the primary care providers have come to expect that from the PHQ-9.
Okay, thanks.
Justin.
John, yeah, you mentioned the PMQ-9 for the kind of the longitudinal measurement-based care. You maybe mentioned this earlier and I could have missed it, but what did you use for screening bipolar on the front end? And did you say everybody had like kind of a required confirmation visit with the psychiatrist, even in the telecollaborative care arm?
Almost everybody did, yeah. So it was the CIDI.
Oh, okay, yeah.
Von Kessler's, which starts out with a 2-question screener. If you say yes to either one, there's a 3rd question about irritability. And if you say yes to that, there's 9 more questions. So you had to score an 8 or more on the CIDI.
Gotcha.
3.0 to be specific.
Yeah, that's helpful.
So it worked pretty well. It's a lifetime, basically a lifetime mania screener.
It's hard history to gather, period, as you mentioned earlier.
It is. And then everybody the protocol was everybody saw a telepsychiatrist, either consultation in collaborative care or for like the initial diagnostic assessment treatment planning for the referral arm. Okay. And just to go back to this, the top right-hand side there, of all the people screening positive for bipolar disorder, 43.8% got diagnosed with bipolar disorder. That's a pretty good false positive rate.
Yeah. Thanks. That's helpful, definitely.
So we move on to the qualitative findings, which are just as interesting. We did semi-structured interviews with 49 patients from various states, clinics, arms, diagnoses, engagement status, et cetera, and 22 interviews with the primary care providers. I think I'll have time to get through this. Start out with the similarities between the 2 arms from the provider's perspective. So they were happy with both arms. I was very pleased with both arms. This is a primary care provider. And primary care providers would see patients in both arms, so they could directly compare the two treatments. So they have a really good, unique perspective. If one of the other service was to be offered in our community, boy, I would jump at either of them. I know it was a research study and I appreciate that, but as far as we were concerned, it was access to psychiatric care, and that made us really excited about both arms. Another primary care provider said, I could see success in either arm if someone was working with then they named the TER telepsychiatrist, they would come back and they would say, yeah, I'm doing great. I'm doing a lot better. Same with the collaborative care arm. So primary care providers were happy with both these arms. They thought their patients improved access to needed care and their patients did better. There were some differences. So when asked which approach worked better for them, this is a really interesting answer. This primary care provider says the TCC arm, in a sense, was more exciting to me because these are my patients with telepsychiatry collaborative care. They were seeing me regularly for medication refills, and then we had ready access to psychiatric care through the care manager to call down and see how the psychiatrist might suggest changing medications and getting an occasional consult. The TER arm, the patients tended to sort of disappear into a black hole and get their psychiatric care for a year, and I didn't necessarily follow up with them. There was more interaction with collaborative care. I really appreciate the collaborative care where I actually have more input and more feedback from patients. So this was a kind of a common thing people would say. They liked being involved with their patients' care when they had the support from the care manager and the psychiatrist.
That's pretty cool. That's a neat
cool.
finding. Yeah.
And what about the burden? We specifically asked them, was it a burden? Was collaborative care a burden for you? Because we're asking you to treat patients with bipolar disorder, and that's not something they're used to. So this primary care provider said, this is just about collaborative care. I don't know if everybody's set up like that, but we have a lot of good support. So it was not burdensome for me at all because the care managers just set it up on the counter, and I'd send it back and they'd push the button and send the medication, and that was that. Another provider said, I didn't hear any negative. So I'm going to say there wasn't any burden. Okay. A lot of these patients that got enrolled in were patients that were unfortunately can be sometimes burdensome with regards to time. If you've got a patient that was unmanaged, that has unmanaged bipolar disorder, they can take up a lot of your time. And I saw that a lot of these patients did really well and were able to have really productive medical visits. So it was actually the opposite, I think. So this provider is saying that his collaborative care patients with bipolar disorder was getting managed, and so their physical health could be more easily addressed with less time. So that's also cool. And then this is even cooler. This is about the skills and knowledge gained as a part of being a part of a collaborative care team. So in terms of medication management, one primary care provider said it gave me a deeper decision tree in terms of approach to specific medication and when to transition, how to make transitions, things like that, and appropriate monitoring. There were good reminders about doing specific lab tests and maybe an EKG for when you're studying some things, and just being aware of the most common side effects of different things. So I felt like I learned a lot through that.
And Bryn, you've been following along with all the emails.
And then specifically with bipolar disorder and collaborative care, I learned how underdiagnosed bipolar disorder is. And I'm starting to now see that in several more patients where I probably would never even thought to look for it. That's opened my eyes a huge amount to treating mental disease and looking for other diagnoses because bipolar is so hidden within depression. And with PTSD, a primary care provider says, my prescribing practice now mimic a psychiatric consultant. There's a level of comfort now where I would be comfortable starting some medications for PTSD while waiting to try to transition and get further help. So they appreciated what they learned, these secondary gains of collaborative care. And of course, patients said they love collaborative care too. Excuse me, I'm very forgetful. I forget about my appointments all the time. So my care manager would call, ask me if I was going to be there, let me know ahead of time so I wouldn't miss. She was understanding if I missed and everything, so she was great. I couldn't talk to her about anything. Another patient says, like I said, I had the care manager's direct phone number. I knew I could call her, message her, whatever. I knew that it was there. So it was really easy access to that. Sorry.
And just John, real quickly back on the comfort with the meds piece. Do you know, do you have any sense of, yeah, they prescribe more second generation antipsychotics or lithium or Depakote, or any sense of what they were being asked to do or how the recommendations, because, you know, things have changed a little bit since the good old days of Tegretol, Depakote, and lithium with all the SGAs.
No, we haven't analyzed that data.
Okay.
That's still
Okay.
in CTS. That takes a little time to analyze. That probably is the next thing we're going to do. Sorry, I don't know.
Okay, thanks.
Some of the patients really like the referral care as well. So one patient in referral care said, I think the biggest thing that helped me was the telepsychologist. She gave me homework to do, which made me have to pay attention to what I was doing every day. And I think that made a big difference. This was a subset of patients who appreciated the structured psychotherapy, protocolized psychotherapy with homework, which not all of them did, but the ones that did really liked it. And similarly, a provider says there were certainly some patients that wanted the more classic CBT therapy, would have maybe done better in the referral arm. So there's a subset of patients who say they liked the referral and the providers think they did better in the referral arm. So just to conclude, patients and providers were satisfied with both collaborative care and referral care. They thought improved access to specialty care and improved outcomes. The provider perspectives on collaborative care, they liked knowing what they're going on with their patients. They didn't feel overly burdened. They appreciated attaining new knowledge and skills. And then patients liked having a care manager. And then some patients did like the structured psychotherapy. So I'll leave you with a beautiful picture of the Skagit County's Tulip Festival up here in Pacific Northwest. Anyway, we got a couple minutes for questions or comments.
Just to clarify, John, the telepsychologist and telepsychiatrist that were on the referral end, were they the same people that were in the transitional care, or was that a total different team?
They were, at each clinic, they were usually different people. So the telepsychologist at the university would not provide telepsychiatry consultation and telepsychiatry referral care to the same clinic. Okay. Just to avoid confusion and contamination. We had one patient who got contaminated who was in the collaborative care arm and got referred to the referral telepsychologist. But for the most part, we managed to minimize that. There were some in Michigan, some of the sites, a psychiatrist would be a collaborative care psychiatrist in one clinic and a referral psychiatrist in another clinic.
John, in the tele-collaborative care arm, the care managers, you mentioned behavioral activation. Did they ever kind of move over into more short-term CBT kind of interventions too? Because it sounds like some of the patients maybe, or at least the provider, wanted maybe a little bit more of that structured care.
I don't think so. You know, we did a lot of training up front in behavioral activation. There was actually a version of it developed at the Seattle VA that focused on a little bit of exposure for the PTSD. And they had to document using that in our care manager tracking system. I mean, therapists can't help but to, draw bits and pieces from different therapies at different times during the session. But so I can't say for sure they didn't use some cognitive, cognitive therapy as in addition to the behavioral activation. A lot of them were nurses, so they wouldn't have done that. But some of them were master's level psychologists, and they could have done that.
Gotcha.
We wouldn't have observed it.
Yeah, and I love that you
confessed to it.
I love that your comparison group still had the measurement-based care, even though in reality we know that is maybe not the case. So these results maybe would be even more robust than the real world.
Well, there was a trial that is essentially the same trial without the tele, called the PRISM-E study. Some of you may remember PRISM-E. It was basically a behavioral health consultant model versus an off-site referral model. And they had really poor engagement, more like the 25% in the referral model, and they weren't using measurement-based care, and their outcomes showed no improvement over time. So I think measurement-based care partially explains that. We were using it and they weren't.
Yeah, interesting. Yeah, that treatment to target is I remember you saying that back in Little Rock many moons ago. That's maybe the most active factor in all this.
Broken record. All right, Patty, do you probably have an announcement for the next conference or something?
Yes. Next month, June 1st, will be Neftali will be presenting, talking about the practical application of the different models in real life, different examples of how these models are being actually implemented in different clinics. So it should be some good discussion. Seems like people are mostly presenting one model or the other. So that'll be Neftali. And then in July, we're hoping to get someone talk about training residents in a collaborative care management model.
Cool. I see in the chat that someone's asking to share slides. I'll send those to you, Patty.
Great.
Fix my one typo and send those to you.